My talk will deal with the chemotherapy-induced side effects. As you can see the title here, I'm interested in chemotherapy-induced side effects and also the role of serotonin and how to modulate the serotonin in various chemotherapy-induced side effects. So I am primarily interested in chemotherapy-induced side effects and mostly in neuropathic pain. So this is my main interest. And with relations with the serotonin, I'm also interested in the anorexia. So I will talk about both chemotherapy-induced side effects today. So first, let us start with the chemotherapy-induced neuropathic pain. Several years ago, Pfizer, the pharmaceutical company, organized a body painting, organizing meeting with the actors to show how neuropathic pain is severe and that patients should be treated with neuropathic pain. And although I was not invited, I was really curious to see and to know how the body painting and actors will represent the neuropathic pain. And to my surprise, I saw that really this body painting and actors indeed represent well the neuropathic pain. The neuropathic pain is characterized by like burning and stabbing pain. And as you can see here, you have the red lines showing the stabbing pain. And also you can see the like worms walking because it has some abnormal sensations. And you can see in this face of the actors that it is really a severe pain. So neuropathic pain is indeed really a severe pain. The International Association of for the Study of Pain says that neuropathic pain in fact affects the somatosensory nervous system. So it is caused by a structure or functional problem of the somatosensory nervous system, and it is a severe pain. Neuropathic pain is characterized by dysesthesia, which is an abnormal sensation. And within dysesthesia, there is allodynia and hyperalgesia. So allodynia is a non-painful stimulus which become a pain, and hyperalgesia is a small pain which becomes a bigger pain. So these are the two pain characteristics of neuropathic pain. So there are a lot of different types of neuropathic pain. You can have a diabetic-induced neuropathic pain and postoperative neuropathic pain, trigeminal neuropathic pain. But what I am interested in is CIPN, which is chemotherapy-induced neuropathic pain. There are a lot of neuropathic pain drugs, as you can see here in the figures. I don't know if you can see the red dots that I'm showing. But among the many chemotherapeutic drugs, mostly the platinum-based and vinca alkaloids and taxane-based drugs are the most drugs that induce the neuropathic pain. Among the platinum-based drugs, there you have oxaliplatin, and among the vinca alkaloids, you have vincristine, and among the taxanes, you have the paclitaxel. And you can see here in the figures that the oxaliplatin targets the ion channels, and taxanes mitochondria, and taxanes all again microtubule. But until today, the pathophysiology is not completely understood, but we think that there may be more functional problems in the axon and meninges and cell body. The clinical features of CIPN chemotherapy-induced neuropathic pain is primarily polyneuropathy. It does not affect only one part of peripheral nerves, but several nerves. So you can see here, when we talk about the CIPN, we always talk about the stocking and glove distribution. You can see here the blue colors, and then the forelimbs, the arms, and the legs are in blue color, and this is where the symptoms occurs. And mostly it is severe in the fingers and the toes. As you can see that there's a color more colors, blue, deep blue colors. And the patient's symptoms is numbness, tingling, and burning, and shooting, stabbing. But the factors that can induce these symptoms, that can make these symptoms bigger, is cold. So patients has more severe symptoms when it's in winter period, and especially when you have like a cold stimulation. So usually the patient says they cannot even open the fridge because it's a too painful stimulus for them, and then they cannot deplace like their like boxes and things in their fridge because the cold which is normal for us, is too severe for them. And the prevalence of CIPN is, as you can see here, like with study from 31 study and with including over 4,000 patients, you can see that in first month, 68% of patients have a CIPN, and then after 3 months, it decreases a little bit, but you still have, even after 6 months, you still have 3% of patients saying that they have these symptoms. So you can see that is really high prevalence, and among the 3 chemotherapeutic drug that I talked to you about, oxaliplatin and paclitaxel and vincristine, they have a little bit of differences, but they have almost like more than 50% of prevalence rates. So this is really important to treat this chemotherapy-induced neuropathic pain because it can also interrupt the chemotherapy schedule. Usually patients receive chemotherapy treatment every 3 weeks or 4 weeks. And then if the pain is too severe, their treatment schedule is interrupted, or their dose will be decreased because it's too severe and it's really harmful for them. And it also decreases the quality of life. And you can see that with the patient, they already have cancer, and plus with the chemotherapy treatment, they can have the CIPN. They have more depression, more anxiety, and sleep disorders. So these are the factors that decrease the quality of life. So the treatment of chemotherapy-induced neuropathic pain is really important. So how the CIPN is prevented and treated now? For the prevention, unfortunately, it says that there is no good prevention. It says that the good way to prevent the CIPN is to not give the drug or to decrease the dose. And even the American Society of Clinical Oncology says that we don't recommend any drug for the prevention of CIPN. When it comes to the treatment, you have duloxetine, which is a famous drug for serotonin norepinephrine reuptake inhibitor. And then you have also tricyclic antidepressants. But the American Society of Clinical Oncology recommends duloxetine as a drug to decrease CIPN. Not only talking about the chemotherapy-induced neuropathic pain, but when you talk about the pain in general, usually you have the stimulus coming from the peripheral side, and it enters the central nervous system, and it goes from the spinal cord to the brain. But in this peripheral nerve or the central nervous system is affected when you have the neuropathic pain. But our body have our endogenous system to decrease the stimulation, the transfer of these strong signals. In our brain, there is 3 sites that synthesize opioid and norepinephrine and serotonin, and we call this the descending pain inhibitory system. But when in chemotherapy-induced neuropathic pain, it says that opioid does not really work very well. And to use opioid as a drug, you have to increase the dose, but when you increase the dose, because of the receptors, many receptors present throughout all our body, it has 2 big side effects. So opioids is not really well used against CIPN. So you have norepinephrine and serotonin, and the duloxetine, which is also a norepinephrine and serotonin reuptake inhibitor. So normally, physiologically, our nerve synthesize norepinephrine and serotonin and release these neurotransmitters in the synaptic cleft. But when you have SNRI, serotonin norepinephrine reuptake inhibitor, the serotonin and norepinephrine reuptake is inhibited, and so you have more serotonin and norepinephrine in the synaptic cleft, which can act more for a longer period. So, among serotonin and norepinephrine, I was interested in serotonin. Sure, in our lab we also conduct with norepinephrine, but today's I will focus on serotonin. Serotonin is a really well-known monoamine neurotransmitters. I think you all already know about the serotonin. And in the body, most of our serotonin is synthesized in the digestive system. And the small part, only like 5%, less than 5% is synthesized in the brain. But this serotonin synthesized in the brain has a big role in physiologically in our body for it comes the mood and also sleeping, and in the peripheral side the serotonin acts as a digestive modulating role. And plus the reason why I was interested in serotonin because is that as I told you before, the quality of life decrease. You have anxiety, depression, and sleep disorders. So I thought that modulating the serotonin not only will affect the CIPN, but we could also decrease all the effects induced by cancer and the chemotherapeutic drugs. And so, as I told you, now the serotonin has a lot of many effects, and it is really well a lot of experimental research. So a lot of papers are present about the serotonin. It can act in the central nervous system, limbic system, and gastrointestinal system, and so on. So I was interested in how could we modulate the serotonin system without having a big side effect with a herbal medicine. The thing that I was interested in is ginger, which is really well-known herbal medicine drug. And ginger is known to act in a digestive problem, and especially for nausea and vomiting. And it acts as as a serotonin receptor inhibitor. So I thought that there will be many research on ginger and pain, but to my surprise, there was almost no paper on ginger and neuropathic pain. I could only find, including the ginger and its subcomponents, I could only find less than 10 papers on the ginger effect of pain. So I focus on ginger, and so ginger, I did more research on ginger, and I could see that mostly on ginger there's a digestive stimulation, anti-inflammatory, and anti-diabetic, and cancer-preventing effect, but there is no last report on neuropathic pain. And sorry for writing in Korean, because I thought that today I could talk in Korean, but so I put some Koreans, please excuse me. And even in our Oriental medicine book, it says that ginger has a more digestive effect. So this is also in Korean, so I thought that the ginger, which is well known to have its digestive effect, could be used to treat chemotherapy-induced side effects, and especially neuropathic pain. So in our lab, we made a model of chemotherapy-induced neuropathic pain with oxaliplatin and paclitaxel, and you can see that with oxaliplatin, single injection induced pain in mice and rats, like acute pain for cold allodynia and mechanical allodynia. And also with paclitaxel, you have to inject several times, and there's a cold allodynia and mechanical allodynia. So this is the pain induced cold pain and mechanical pain. You can understand like this. And for the mechanism, I was interested in spinal cord because the stimulus comes from the peripheral side and it enters the spinal cord. So I thought that modulating the spinal cord, the neurotransmitter in the spinal cord, may be effective in decreasing the pain in our body. So first, we had a ginger extract, water extract, and then see whether it could decrease the pain. And we see that it was not really a strong effect, but for 1 hour, the ginger extract decreased the pain. And afterward, so we see that ginger could decrease the pain. We moved to the spinal cord, and we did a pre-treatment of serotonin receptors. First of all, we did 1 and 2 receptor antagonists, and we see that the effect of ginger was blocked, showing that ginger acts through serotonin receptors. So I moved further on and saw that the serotonin receptor 1, but not 2 is affected by ginger. So ginger passed through 1 serotonin 1 receptor, but not by 2 receptors, and also 3. So 1 and 3 receptors is important in the effect of ginger. So we had the data that the ginger extract could be used to treat chemotherapy-induced neuropathic pain. So we conducted the HPLC to see whether the percentage of gingerol and sugarol, which are the main components of ginger. We decided to choose gingerol and sugarol because they are known to pass the BBB freely, and so we thought that it will be more effective in decrease the pain in the spinal cord. And this is the data of sugarol, and this is the data of gingerol. And we see that sugarol and gingerol decrease the pain almost equally, but sugarol had longer effect this is not shown here, but almost 3 to a little bit 5 hours. So we focused on shogaol. So we moved to our next study with shogaol. And first, we wanted to see whether the depletion of serotonin could affect the pain induced by chemotherapy treatment, and so that the serotonin depletion did not really increase the pain. And we moved afterwards, so wanted to see whether serotonin receptors present in the spinal cord will be affected. The gene expression of serotonin receptors will be affected by chemotherapy treatment. And daily, from day 0 to day 5, every day we had some mouse and sampling and so that the serotonin receptors gene expression significantly changed after the chemotherapy treatment. So afterward, we move to the spinal cord and see whether the serotonin level changed. And so that in the chemotherapy treatment, serotonin level and its synthesizing enzyme decrease, and with shogaol treatment, this also increases. And furthermore, we want to also see whether with shogaol treatment, the serotonin receptors 1 and 3 receptor gene expression and protein expression changes, and indeed they changed after shogaol treatment, showing that the serotonin and serotonin receptors present in the spinal cord is important in the action of shogaol. So we wanted to verify once more with the antagonist treatment that indeed serotonin receptor 1 and 3 is important in the effect of shogaol as in the ginger extract. And see that 1 and 3, but not 2A receptor antagonists block the effect of shogaol, showing that indeed shogaol acts via 1 and 3 receptors. And we choose some agonists to see whether the effect of shogaol is similar to this agonist, and see that we didn't show the dose dependence of several agonists, but we see that this dose which is effective in pain indeed have some pain decreasing effect as similar to 6-shogaol. After we did some research to see where the serotonin receptor 1 and 3 are present in the spinal cord, and we see that they are present mostly in the inhibitory interneurons, which produce GABA. So by doing immunohistochemistry with shogaol, we see that in the oxaliplatin, this is the dorsal horn of the spinal cord, the the number of GABAergic positive neurons decrease, but with shogaol, it really increases high. It was stronger than we expected. And in the spinal cord of antagonist-treated rats, we see that the expression of GABA positive neuron is decreased, showing that the antagonists 1A and 3 indeed block the effect of shogaol and block the expression of GABA. And so we did the Western with the GAD65, which is related to GABA, and also we did the ELISA treatment to see whether indeed in the spinal cord the GABA expression decreases and increases with shogaol treatment. So we had a summary with our experiments. Is still going on, but until up to now, this is the summary that we had. So we think that shogaol treatment increased the TPH2 enzyme and increased the synthesization and release of serotonin in the synaptic cleft, and increased the action of serotonin receptor 1A and 3, and decreased the oxaliplatin-induced neuropathic pain. But in the simultaneously, you have the 1A and 3 receptor expressed in the GABAergic neuron then, so it could increase the GABA release and decrease the neuropathic pain. So this is the data we had with the shogaol. But this was interesting for me because I was always curious whether the pain induced by neuropathic pain is affected by excitation of neurons or inhibition of neurons. Because you can also have the increase in the excitation in neuropathic pain, but you can also have the decrease in inhibition, making the excitation, normal excitation, looking bigger. So afterward, we move to the brain. But in chemotherapy-induced neuropathic pain, the brain is now really well studied because we mostly focus on the peripheral side. dorsal root ganglion DRG and the spinal cord and not in the brain, because we say the chemotherapy treatment does not really penetrate in the BBB and is when you have the brain and see how much of concentration of chemotherapy drug present in the brain is really, really low. But recently some papers says that even with the less amount of chemotherapeutic drug, it can affect the brain and change the astrocytes and change the pro-inflammatory cytokines in the brain. So I was curious to see whether in the brain with the slice, we did the electrophysiological study. We had a brain slice of normal mouse, and we stimulated here in the corpus callosum and recorded in the layer 4 of the cortex and see whether the inhibition excitation ratio changes. So this is the normal inhibition excitation rate in the brain. So you can see that normally in the brain the inhibition is bigger than the excitation. The blue part, if you can see the red dots, but the blue part is the inhibition and the red part is the excitation. So you can see a big current of excitatory postsynaptic current of inhibitory postsynaptic current, big current of inhibition, and excitation is smaller. But after the 2 hours incubation of paclitaxel, you can see that the inhibition current decreased, but the excitation currents remain the same. And when you compare the excitation inhibition ratio, it changes because not of the bigger excitation current, but due to the decrease in the inhibition current. So we move. So as this data was in the slice, we wanted to have a slice of normal rats, which was induced with SM in our previous study. So we injected paclitaxel several times, and 1 month after we had the brain slice in this mouse, and see that the results was almost the same. So the control has a bigger inhibition current, and paclitaxel, the inhibition currents decreases, and in the same, the excitation, we say EI ratio, excitation and inhibition ratio changes not because of the excitation, but because of the decrease in the inhibition. So with these interesting results in our lab, we are trying to find herbal medicine or acupuncture and way to find how to increase the inhibition, the GABAergic or inhibitory neurons, the function of inhibitory neurons in chemotherapy-induced neuropathic pain. Now I will move on to the second part of my talk, is chemotherapy-induced neuropathic pain. So I told you that basically I did most of my research, I did neuropathic pain, and chemotherapy-induced anorexia is almost new, but this is also very interesting to me. For chemotherapy-induced anorexia, cisplatin is the chemotherapeutic drug which induces anorexia. So cisplatin is a well-known platinum-based drug, I think you all know, and it also has side effects as every other chemotherapeutic drug. It can induce vomiting, nephrotoxicity or toxicity, anorexia, but it does not really induce neuropathic pain, the cisplatin. So chemotherapy-induced anorexia is also a big problem because sometimes it's not really severe, but clinicians tell me that it's difficult because acutely it's really severe, and although it does not last really long, but it could affect the patient's quality of life and also interfere with the treatment. So treating chemotherapy-induced anorexia is also important as chemotherapy-induced neuropathic pain. Currently, the drugs that is used to decrease the chemotherapy-induced anorexia is MGA, megestrol acetate. This is a steroid-based drug and is approved the FDA in 1993. But it can increase the weight in patients, but it's mostly by fat and edema. So it can also cause some side effects, and you have also some minor side effects like diarrhea, skin rash, insomnia, and fever. So my interest was as ginger affects the digestive problem is also well known, but in our previous study, the ginger was acting as a serotonin increasing drug, and so I want to see in our lab, we want to see whether ginger can also decrease the serotonin in cisplatin-induced anorexia. So we did the modeling with rats. And so we see that the 6 mg per kg of cisplatin could induce acute anorexia in rats. As you can see in the red lines, normally rats have like 20 grams, eat 20 grams per day, but you can see for 48 hours, it only has 10 grams of their food. And the body weight also does not increases. And you have the total water intake also decrease. And you can see the G is the ginger extract, and the ginger extract was effective. The blue is 100 mg per kg of ginger, and the red is the cisplatin only treated group. And you can see that it significantly increased the food intake in rats, and the body weight also increased it in 100 gram of ginger. Although the 500 gram increases the appetite, but it did not really increases the weight. So we moved to our further research with 100 mg per kg of ginger. And then for our mechanism, we focused on nodose ganglion. So this is the nodose ganglion in the peripheral side. This is where all the signals from the digestive system, but not only, there's also liver and pancreas, the information going to the nodose ganglion, and goes to the NTS, nucleus tractus solitarius, which is the appetite controlling side of our brain. So we moved to the nodose ganglion and see whether the change in the nodose ganglion is affected by cisplatin and also by ginger treatment. And we can see that the increased serotonin in the serum and nodose ganglion significantly decreased after ginger treatment, and the serotonin receptors that we targeted also changed. The 2 was not effective, but 3 and 4 was targeted by the ginger treatment. And furthermore, we did some Western blots to measure the protein expression in the nodose ganglion and see that the 3 and 4 receptor expression of protein significantly decreased after ginger treatment, showing that the serotonergic system in the nodose ganglion is also important, and this is affected by ginger treatment. And afterward, we want to see whether the antagonists, well-known antagonists, palonestrone and piposerod of serotonin receptors could also be effective in cisplatin-induced anorexia, and so that we had the result that it also has decreased the cisplatin-induced anorexia like in the ginger-treated group. And this is our final data. And this was interesting because as in the chemotherapy-induced neuropathic pain, we wanted to move to the subcomponents like shogaol and gingerol. But when we injected gingerol and shogaol, independently, they were not really effective. But so afterward, we moved the gingerol and shogaol combination, and when it was combined, when they were treated simultaneously, the effect was similar to ginger effect. So by this result, we saw that the shogaol and gingerol present in the ginger is an important component and play an important role in the effect of ginger. So yeah, so this is the the conclusion is that serotonin modulation could be effective in decreasing different types of chemotherapy-induced neuropathic pain. In our lab, we are interested in different types of chemotherapy-induced side effects. We also conduct fibrosis in relation with the serotonin, but today I did not bring the data. But if you have interested, we can have a talk later. And so the conclusion that we get that ginger can modulate chemotherapy-induced side effects, but by 2 different ways. It decreases this chemotherapy-induced neuropathic pain by increasing the serotonergic system, but in cisplatin-induced anorexia, it decreases the serotonergic system. So we are moving to our further research to see how ginger can act these 2 different ways, increasing and decreasing the serotonin system in treating these chemotherapy-induced side effects. Hope that I will have the chance to talk again about my research afterwards. So this is the end of my research. So this is my lab member and the PhD which conducted most of the studies. Thank you for listening, and thank you.